Welcome to the Pulse of Healthcare. It's Dr. John McCormick. I'm here with Peter. We're going to talk today about pre-authorization or prior authorization. Is it good or bad? Well, what's the purpose? We touched on this probably several episodes ago, but today I was looking at LinkedIn and I saw lots of rants from physicians that were, like, this is just a gatekeeper model and it's bad for the members and people don't get care as a result of it. And certainly that could be true for the major carriers that are using pre or prior authorizations to restrict care or narrow care or gatekeep in some way. But there's another side of that coin that they don't talk about it and they don't explore. And I just kind of wanted to touch on that just for a few minutes today.
You know, Dr. John, recently I went to the doctors and they referred me to another doctor who was going to order some tests for me, and I was told I had to get pre-authorization in order to have those tests done, which delayed care for a week before I could get through that whole process.
Right. Right, and that's not convenient, and it certainly could be considered bad medicine depending on the case, right?
Right.
So, but let's I'm going to flip the script on that a little bit because, we're a concierge medical service at Ovation, and that means that you call us, we'll help set your appointment. So we effectively are pre-authorizing your care at the primary care level, at the specialty level for any service or any test you need. Now, granted, many of the services that we provide are zero deductible, zero co-insurance, there's no copay for labs and imaging and things like that, but you do need to coordinate your care with us and through us. That's not a gatekeeper model the way it's being described by the physicians. The reason we have to do this is because they don't charge the same prices, right? So we've had a lot of questions about this. Like, why do you coordinate care? Well, because our role as a plan and as a TPA and as a, responsible fiduciary, we share that fiduciary responsibility with the employer, who's ultimately the fiduciary, right? Who then ask us to go out and make the best deal for them and their members and be a watchdog for their funds so they're spent wisely for the best care, right? And what happens is, we can call a physician's office and one day it's this rate, the next day it's another rate, the next day it's another rate, and it's the same thing. We can literally call the same hospital 5 different times for the same procedure over the course of the year and get a different price every time. All right. So if they were standardizing pricing, like an auto mechanic or, any place else you go, right, at the grocery store where it's all listed and it's very public like it should be, then we wouldn't have to do that because we could literally just pop up the menu and order off the menu and go, we need you, we would like for you, here's all the places you can go that are within your plan's authorized price range, and you can go to any of those places, wide open, right? But what happens is, if you're not one of the major carriers and you go to some random doctor, now it could be, the doctor you've seen, but now you've changed plans, and you're with one of these, I'm going to say no-name plans, like you're with Ovation or you're with High Plains Health or you're with one of these other places that say you can go open access. We'll pay fair rates to anybody that will accept them. And then you go through and the front desk at the doctor says, we don't take your insurance. Do you take cash? Sometimes the answer to that is no.
Yeah.
All right, and you're like, hold on a minute. Of course you take cash.
When did
right?
cash go out of style?
Right, when did cash go out of style, right? And then the next day you could go back in there and if you did somebody different working at the front desk, they would say, oh yeah, we take cash, here's the rate. So the lack of standardization at the physician office level, primary care, specialty care, surgery centers that don't post their rates online, God bless the ones that do, hospitals that don't that don't have standardized rates or vary depending on who's calling in, right? That's part of the driving force for pre and prior authorizations, is because you can't have somebody go to get a procedure that costs 6 to 10 times more at hospital A than it does at hospital B, you know? And we use pregnancy and delivery as an example all the time, right? Here in Houston, several hospitals we work with, cash rates, $5,600 for a regular delivery, $7,200 for a C-section, you know. But if you go down the road to hospitals we don't work with, $20,000. If they were all the same, I wouldn't have to worry about it. My member could literally go anywhere and you would have a standardized rate for a standardized procedure. But we don't. Because they charge different rates, we have to help guide our member to get high quality service at a fair price. So I just thought it was so important to jump to the other side of that equation and go, pre and prior authorizations is not evil and it's not bad. Should it get in the way of care, like Peter said, should it delay you for a week? No. But again, you have to go back and go, hold on a minute, why was it delayed a week? Was that the carrier's fault? Maybe the carrier placed a call to get you authorized that day and the provider didn't respond to them. You know how many times that we get a request for authorization, we turn it around in 24 hours and say, here it is, this is what we'll do. And then we meet radio silence until the day before or the day of the requested procedure. And then somebody at the office goes, oh, we don't have the authorization we need. It's your insurance company's fault. No, we responded 2 weeks ago when the member, when we got the initial request, you never responded to, you never signed your part of the authorization and sent it back, Yep. But that's not the story that the member standing in front of the doctor gets. The story they get is your insurance company's evil. That's not necessarily the case. Does it happen? Absolutely. All right?
Yep.
But as I said many times, in this world, we deal with human beings all the time. Everybody makes mistakes. We make mistakes. The doctor's offices make mistakes. Hospitals make mistakes. The billing company makes mistakes. Sometimes we agree to a certain price, and then it goes to some billing company. I hate to say a lot of times foreign billing companies, and they didn't get the memo to say this procedure is being done for this amount of dollars, and so they generate some random bill, and we have to be able to go, no, that's not it, and change that.
But that's also not how the doctors are positioning it. They're positioning it as, can you get this additional care you need, and not talk about the pre-authorization or the costs involved. So as a patient, you wonder, why am I being denied this coverage or this additional service?
Right. Ultimately, you weren't denied, right? In your case, ultimately you got it. It just seemed to be a delay.
Yeah.
But, if you were able to get both parties on the phone, they would be pointing fingers at each other.
Exactly.
And the member should not be involved in that. I guess the point I'm trying to make is, if it was all fair and equal, and you could shop as a consumer and a plan as an employer and knew what you were going to pay, then you wouldn't have to have a pre-authorization.
Right.
All right? And you wouldn't need any of those things. But unfortunately, there are bad actors on both sides of the equation. Sometimes physicians are requesting more procedures than necessary because, let's face it, and we've talked about this, there's a perverse incentive in our medical system because the more you do, the more you get paid. That's wrong. That's wrong. It should be, I'm treating you the best way I can, but I'm also conscious of the cost of care. All right. So, if it's, well, if I do this, I make $100. And if I do this, I make another $200. If I do that, I make $1,000. But really all I needed to do was A. All right.
Right.
Then I should have only done A. And most physicians would have only done A. But like I said, there's bad actors on both sides of that equation. Right? As we know, some pharmaceutical companies and other things perversely incentivize doctors to prescribe certain medicines, to do certain procedures. If your whole operation is based around a certain procedure, well, by God, you're going to recommend it every time.
Yeah. It's I know an orthopedic. I went in. I got shots in the knee. They were recommending knee replacement.
Right. Did the shots cure it?
Yeah.
Did you make the choice for the shots?
Yeah.
Right. So you basically went against your doctor's orders and said, you know what, I'm going to try this shot thing first. And by gosh, I didn't need knee replacement. And that's, I've had several people in my life that have had knee replacements and hip replacements, and some of them have gone phenomenally. And sometimes people have almost died from the blood clots and the infections and the other things. So I'm not anti-surgery if you need it and it's going to save your life. But if there are other options, I think you ought to explore those. I think we were talking right before we started this show about, people making decisions. And I made some quip about, if you tell somebody they have cancer, they'll jump right into the most invasive procedure and, a year worth of chemotherapy, which is effectively poisoning yourself, right?
Right.
In a hope that they'll get cured. And of course, there's no guarantee, and unfortunately, many people die from cancer.
Right.
And that's terrible, right?
Right.
But if you were to rewind their life and say, if you didn't eat the processed foods and you died and exercised and you spent a little bit of time out in the sunshine, things like that, your likelihood of getting cancer would have gone from 70% to 5%, and you probably would have never had it. But they're like, I don't want to stop eating Doritos. No offense, Doritos. I don't know if you cause cancer or not. And what do you mean go outside, right?
Yeah.
And then now we're conditioned, if we go outside, we put on sunscreen, right?
Right.
Except if you read today's study, sunscreen causes cancer,
Sure.
right? Whereas the sun is good for you, all right? And it's really bizarre because it evolves all the time. And you have to really dig down to what was the root cause? Why did we start doing things we did? And, I hate to say follow the money. And who was getting paid as a result of it? How were we healthier years and years ago? I mean, if you look at child autism rates, the answer is a resounding yes. I mean, we went from autism at 1 in every 100,000 children to 1 in almost 36 now. Childhood diabetes off the charts. Childhood diabetes almost didn't exist in the 1970s. What changed?
Yeah.
Processed foods, sugar, all the stuff that we've added to our diet. You go back and look at TV and movies from the early 1900s all the way up to 1950 and 60. People are fit, they're thin. I'm not saying there weren't heavy people back then. Certainly there were. All right? But you look at obesity rates now in America, off the charts. What changed? What we eat. What are the, clinical knock-ons of that? We're heavier, we're more diabetic, we have more cancer. I think then they might all be related, right? So obviously that was a digression from pre-authorization, but the point is not all pre-authorizations are bad, and unfortunately the way the system is designed, all right, they're needed to ensure that we're getting high quality care at the right price for the members. I would love for all the doctors in the world, the ones that are owned by the hospitals and the ones that are owned by Wall Street, to all suddenly come together and say, you know what? Based on our region, because cost of living changes everywhere we go, Medicare, if you didn't know, scales depending on where you're at. You get paid more. All right. Well, why can't we just set flat rates for everything? Here's a procedure, here's a flat rate. I mean, that's what Medicare does. It's already there, it exists. Those numbers exist. Adopt them. Add 10%, 20% if Medicare is not paying as much as it needs to. But don't let me walk through your door as a Medicare patient at 65 and me get charged one rate, but at 64, because I'm an employee, get charged 600%. That's To me, that's robbery. You know, and that's why prior authorizations are needed. Anyway, that's my rant today on the pulse of healthcare.
But it's a good one that people should understand.
Man.
And I, even working through it as I did, didn't like the process I was going through, but it was protecting me as I was going through it.
Right. You know, and it's, like I said, sometimes we take a more tedious path, but it's also more thoughtful. And so, you know, at the end of the day, people want to get great health care. And sometimes that means it's a little inconvenient. All right. Well, that wraps up today's episode. Thanks, Peter.
I appreciate it, Dr. John.
Check us out again
Well
on the
done.
Pulse of Healthcare.